Chair Hartman and members of the board, departmental item number 4 is from the County Executive Office. It is a hearing to consider recommendations regarding an update on the coronavirus disease 2019 COVID-19.
Thank you. Dr. Del Reynoso.
Good afternoon, Chair Hartman and members of the board. Both Dr. Ansorg and I will be providing your board with an update on COVID-19. Next. To begin, I'd like to present to your board a summary of our numbers. Our new cases stand at 780. We reported 2 new deaths, and these are both are individuals who were 70 plus years of age, had underlying medical conditions, but not associated with a congregate care site. The individuals resided in Santa Ynez Valley and Santa Maria. With regards to active cases, we are reporting 5,645. We have 139 hospitalized with 17 in the ICU. Our total case count is 73,544. Total deaths stand at 587. Our case rate per 100,000 is 181.02, with testing positivity at 23.4. Next. Similar to many other counties in California, Santa Barbara County's coronavirus transmission numbers continued to improve over the weekend. It appears that we may have peaked and hopefully passed the worst of the Omicron surge. However, COVID-19 case and positivity numbers remain well above pre-Omicron records, meaning that we are still at highest levels of transmission than we have ever seen at a case rate of 181. Next. This graph describes our case rate by vaccination status. As of January 13, our case rate among unvaccinated individuals is 631 per 100,000 versus the low 154 per 100,000 among vaccinated individuals. This means that in Santa Barbara County, unvaccinated individuals are 4 times more likely to get COVID than fully vaccinated individuals. The data that we are presenting in this graph continues to show the compelling difference between unvaccinated and vaccinated infections. Also noted is the unvaccinated case rate has a significantly steeper increase compared to the vaccinated case rate, which is beginning to trend downwards. Next. Currently, there are 71% of hospital beds in use and 81% of staffed ICU beds in use. So of the 595 hospital beds, 420 are in use. And with that number, 139 are for COVID-19. Of the 62 staffed ICU beds, we have Of the 62 staffed ICU beds, we have 50 in use, with 17 of them for COVID-19. Next. As of 1/24, COVID hospitalizations have increased in our county by 309% in a month. This new surge in COVID-19 hospitalization surpasses values that we saw in the summer. Last week, I met with the hospital CEOs, and we had a conversation about COVID admissions. And so we found that of the COVID-19 patients hospitalized, about 25 to 33% come with COVID, and the remaining came because of COVID. So even even if the COVID patients who are admitted for other reasons, like a real life example of 8 labor and delivery patients who came to deliver babies but were found to be COVID positive upon testing, these 8 will require extra resources to support their COVID state. So COVID state does impact hospitalization. Next. This is a summary of our vaccination rate as of 1/23. We have 78.4% of eligible Santa Barbara individuals vaccinated, and we have 70.1% of eligible Santa Barbara County as fully vaccinated. Next. Our mobile vaccination program continues to focus on areas that are lower in vaccination coverage. Please check our website at publichealthsbc.org for details of our vaccine clinics throughout the county. In addition, we've been focusing on Isla Vista and Goleta to increase the vaccination rates in the 93117 zip code, which has the lowest vaccination coverage in our county. Next. Currently, we have 211 active outbreaks that our team is managing. We have 93 outbreaks among businesses, 48 among schools, and 70 among congregate living facilities. Next. With regards to testing sites, community testing sites, I'd like to update your board that at the 11th hour, we were unable to enter into contract with a site. And so we are exploring and with a second site that we had in mind. So the ETA is unknown for Goleta, the Goleta site, but the state staff are ready to set up shop once we have a confirmation of a site and the contract is in place. With regards to turnaround time for test results, typically we are seeing a 24 to 36 hours for all of us, for all of our sites. However, due to increase in the number of tests performed statewide, we are seeing an increase in turnaround time for results. For the last week, the median turnaround time is 72 hours. Next. With regards to antigen testing, our healthcare center placed 2 orders for a total of 205,200 kits, and each kit contains 2 tests. The number of kits received as of today is 165,996 kits. We have 77 partners that we have engaged countywide to assist us in distributing these kits. We have engaged 25 partners in North County, 15 in Mid County, 33 in South County, and 4 partners who serve countywide. Next. With the distribution of kits, during week 1, which was last week, we distributed 36,450 total kits, and 48% went to North County, 8% to Mid County, and 44% went to South County. This week's distribution will include giving out 71,550 total kits, with 40% going to North County, 22% going to Mid County, and 38% going to South County. Next. And this is a nice graph or a nice map showing where all of our partners are. So we strive to ensure that the antigen testing distribution is widely available throughout our county. Next. Last week, your board inquired about national data in comparison with our state data and our local data. This first slide is about COVID cases in the US, with cases reporting at 690,448, with 157,429 hospitalized and 2,182 deaths. And this is a graph that is very similar, but on a smaller scale, what we are experiencing in California. A note about this national data, across the U.S., we are seeing the Omicron surge starting to recede, with 17 states reporting decreasing cases over the past 2 weeks. Next. So this is COVID cases in California as of yesterday. And again, we are somewhat mirroring the national graphs, but again, on a much smaller scale, with 108,751 cases, 15,829 hospitalized, and 123 deaths reported yesterday. Next. This is comparing trends in cumulative cases. Again, last week, there were inquiries about how our outcomes are compared with regards to Arizona, Florida, and Texas, and other states. And so this is a graph that describes cumulative cases reported to CDC in these 4 states. And these are cumulative cases per 100,000 by submission date. So you have the blue line, which is the top line at 24,899, and that is Florida. And the next line is the purple line with 24,078 from Arizona. And the third line, the lower line in brown, is 20,466 reported by Texas. And the lowest is the green line reported by California at 19,160. Cumulative metrics can help us understand the overall impact of a disease on a population, especially given differences in policies and strategies. We are reporting today only cumulative cases and cumulative deaths because only 36 states and territories report cumulative hospitalizations. So the data around cumulative hospitalizations is less complete. Next. This is comparing trends in cumulative deaths. The top line is purple, and it is this is cumulative deaths per 100,000 by submission date to CDC. The top line is 352 as reported by Arizona. The second line is 298 in blue reported by Florida. The third line is in brown at 265 reported by Texas, and the lowest line is 197 as reported by California. Next. And I'd like to transition to Dr. Ansorg, who will be presenting the next few slides.
And also, Chair Hartman and members of the board, the press is really writing a lot and speaking a lot about when is this pandemic finally going into an endemic phase. And I just wanted to use this opportunity to give some definitions and a little bit of insight in this. A pandemic is a worldwide epidemic, basically, that happens around the globe on a large scale. That's what we're experiencing right now. An epidemic is the same thing, but geographically or in a population with a significant but a limited outbreak of a disease. And endemic actually means a disease that has a constant presence in a certain population or in a geographic area, but it is manageable and it's not causing enough illness to disrupt normal life activities or overwhelm the healthcare system. We are used to, infectious diseases like measles, varicella, mumps, influenza, flu, common cold, and those kind of diseases. They are endemic. They are a nuisance. Sometimes they cause death or problems, but they never overwhelm the hospital system, and they don't make us having to change policies to keep people safe. Next slide, please. So COVID, when is COVID going into an endemic phase? Even Dr. Fauci is very careful because there are certain requirements that would have to be fulfilled. We now understand that the SARS-CoV-2 virus will never be eradicated, but it will remain in the population at some level, and it will cause periodic waves of infections, quite similar to influenza or mumps or the common cold even. For an infection that relies on person-to-person transmission, like COVID, to remain endemic for a long period of time or forever, every infected person, on average, must pass it on to at least another one. The other person has to be susceptible to the virus. So the more people in the population are immune to the virus, a smaller number of people will get infected and the outbreaks will be limited. Next slide, please. So what are the strategies that we have to focus on and take into account for policymaking and recommendations? We need high vaccination rates with boosters. We now know that boosters have an enormous impact on how robust the immunity is against Omicron, for instance. Just last week, the CDC came out with a very good paper showing that that the immunity against the Omicron virus wanes faster within the first 6 months. And that's why it is very important to get a booster to have much improved protection against Omicron. We do have, fortunately, some medications now that are very effective. We have monoclonal antibodies. We've had them for quite a while. Unfortunately, the ones that we have used widely are not effective against Omicron. So as of yesterday, the FDA withdrew the approval for use of BAM80, as we call it, and Regeneron as monoclonal antibodies because they are not effective against Omicron. And Omicron is prevalent is 99% of all COVID infections in the United States. We have, fortunately, one new one. Monoclonal antibody has to be given through an intravenous infusion at the hospital to patients with moderate illness due to COVID, and that would have high risk for poor outcomes. And the drug is called sotrovimab, and unfortunately, it is in short supply. So we are receiving on a weekly basis, even though the CDPH says it's a bi-weekly basis, but we have received on a weekly basis small amounts, and we are giving them to our hospitals, our emergency room of all the hospitals, as well as to the Central Coast healthcare centers. who have infusion site where they can take advantage of this treatment. As probably everybody has heard, there are 2 oral medications also available now. One is called Paxlovid. It's a 5-day oral pill, just like Tamiflu for influenza, for instance. And it is, again, meant for people who are COVID positive with mild to moderate symptoms, not needing hospitalization, and who are at increased risk for poor outcomes, especially people over 65, but already starting at age 50, then people with higher body mass indexes or other underlying conditions have a higher risk for poor outcomes with COVID. And therefore, it's a really important new medication that we have that can be taken at home. We are really hoping that the company is going to produce this medication on a large scale. We just sent a provider alert to all of our medical providers in the county on Friday, giving them clear instructions on whom to prioritize for this drug. And also, the considerations for prescribing the drug, because there are certain interactions with other medications that have to be, thoroughly evaluated before prescribing the drug. Because it's a brand new drug, every doctor has to learn about it. And we are helping in collaboration with all of our outpatient physicians. There is another drug that's been used for a while already. It's called remdesivir. It's also an antiviral, not a monoclonal antibody. And it has to be given intravenously as well. But it is now also approved for outpatient treatment, which is absolutely helpful. It's very effective in reducing severe outcomes and minimizing death from the disease. However, it has to be given on 3 consecutive days with an IV infusion, and that is, of course, a logistical problem. But it is, some clinics may be able to take advantage of this. The last drug by the company Merck is called molnupiravir, and it is really only to be used if there is no other drug available, because its effectiveness is much below, is only 30% as opposed to almost 90% of the other drugs. So we don't encourage that as a first choice, but only if there's no other option available. As we all know, we are all getting more and easier access to self-testing, which is a really big, important part. Because if people can self-test, and then once they're positive, when they identify they are positive, even if they don't have symptoms, they can isolate themselves and not spread the virus further. That is a very important piece to make sure that we reach the endemic state sooner rather than later. In the meantime, we should really keep with social distancing and masking in public indoor settings. We should avoid crowds until this Omicron surge is over. So if this goes according to what we are seeing right now and what we're seeing in other countries and in New York, for instance, we may have passed the peak locally for the Omicron surge, and we are just hoping that it is going down very rapidly, and that we will be at a really safer and better place in the very near future. I would say middle of February. We should see much lower case rates, and hospitalizations will obviously lag behind. Just because we had Omicron is really less virulent. The percentage of people who are infected that require hospitalizations is much lower. Unfortunately, though, we have such a huge number of new infections every day that the end result is that right now we have 139 patients in the hospital. That's a huge increase from even 4 weeks ago when we were talking about 30 people in the hospitals. The ICU stay is not as, ICU care has not increased that much. We have currently 17 in the ICU, and we used to hover around 10 people in the ICU. So if we have a high vaccination rate, as high with boosters as high as possible, if we have more readily available and easy to take antiviral medications, if maybe we get newer vaccines, but I don't see this to happen this year, that will happen, that will protect also against other variants. And if we continue to get even better testing and more available testing and for safety and to isolate ourselves, then we should really be on track to reach an endemic state sometime this year. So is there another slide? Let's look. Just happy people. So I leave that to Dr. Dorenoso, who was, I think, participating in giving out the test kits.
Yes, thank you, Dr. Ansorg. So last Saturday, our healthcare center in Santa Maria hosted a drive-through to distribute 6,750 test kits to the community. Here, joining our team of 9 staff was Director of DSS Daniel Nielsen and Supervisor Nelson. It was a great event, and we were thrilled to be able to serve our community in this manner. Next. What was really sweet is that a little girl approached us during the event and handed us a handful of cards. And this was the front and the back of the card. You know, we're 22 months into the pandemic response efforts, and it is moments like this that really re-energizes us in our efforts to protect our community, to serve our community. With that, thank you.
Thank you, Dr. Ansorg and Dr. Dorenoso. Questions from the board? Supervisor Nelson.
Yes, thank you, Chair Hartman. My question's about the public health testing locations. I saw in there it says turnaround time is 24 to 36 hours. I've been hearing from the public somewhere between 5 and 8 days, which is very problematic, especially since that's often longer than the quarantine period. So I'm just trying to square that. I imagine with the Omicron spike, there was a lot of additional people pushing towards testing, and along with the schools. Was that a temporary glitch, or is that, you know, where are we at?
Supervisor Nelson, through the chair. So at our community testing sites, the state processes the tests, and due to the sheer number of tests that need to be processed, we are seeing anywhere from 24 hours to 72 hours, with the median being in the 72-hour range. So it's nothing that we can do. We checked in with the state, and the state is just the sheer number of cases that have of tests that have to be processed.
Thank you.
And we encourage. So we also encourage community members who are who've been exposed, who are symptomatic, to safeguard their isolation and quarantine period while they wait for the test results.
Yeah, thank you, Dr. Dorenoso. Yeah, so I'm just, 24 to 72 hours I think works. 5 to 8 days, becomes a problem, especially if somebody needs to make a decision on whether they go back to work or not, yet they don't know if they've been exposed. And so it's really problematic. I'm sure you're already sending that message to the state, but just wanted to make sure I relayed that today. Thank you.
Supervisor Williams, then Lavanino.
just wanted a little bit more progress on our effort to get boosters at skilled nursing facilities. You know, obviously, we don't regulate skilled nursing facilities. You're just there to help, but I would like to, you know what you know and what your folks are up to try to help address that.
Our team, we actually have a specific team that goes into our residential skilled nursing facilities, and that was our number one priority to ensure that skilled nursing facilities of large sizes as well as small sizes are given the opportunity to get booster shots. So, to the best of my knowledge, we have made that round, and everyone who needed or who wanted to be boosted have received their booster. So if there are specific skilled nursing facilities that we're not aware of, please let me know and we will resolve that.
Supervisor Lavanino.
Thank you, Madam Chair. So, Dr. Reynoso, you did address something that I keep reading about that it's at the front of my mind. It's with the hospitalizations and the numbers that we see. And I read an article, I believe it was in the San Francisco Chronicle, where they determined almost 45% of the hospitalization number that they're reporting are people testing positive in the hospital, but like you said, maybe there for, a birth or a surgery or something else. And I understand what you were saying about that still impacts the hospital because it's a staffing issue. But it doesn't seem. It seems like numbers we used to use 2 years ago now have a lot less. I guess there's a different correlation. I was just wondering if you could speak to that. It seemed like back in the day it was you had a case, which then means you were probably going to have a hospitalization, which then meant you were probably going to have somebody in the ICU on a ventilator. Where now, case doesn't seem really to relate to hospitalization. Hospitalization doesn't result in an ICU. Can you just kind of talk about that for a second?
Yes, I can start, and Dr. Anstorg may add if I'm missing pieces. But in our conversation with the hospital CEOs, the fact is that yes, we know that with this Omicron surge, that the percentage of hospitalization and correlating percentage of death is not like previous surges. It is less severe, and it is less severe. It has less severe outcomes. But the fact is that when you have 25 to 30, even if you have 25 to 33% of your COVID cases hospitalized came with it, not because of it, it still impacts the hospital with regards to the attention and the resources to treat the COVID state. And we are happy to report that it looks like Omicron is not requiring a high level of ventilation usage as we did previously. But again, the sheer number of cases, and even if we look at a smaller percentage of that going to the hospital, it is still quite large. Dr. Ansel, do you have any additional comments?
Yes. Even Supervisor Laminino, you're right in that there are definitely patients hospitalized in California and across the country who would not need hospital care for their COVID infection. However, that varies from area to area. It also depends on how active an individual hospital is with elective procedures, for instance. I know that Cottage Hospital has scaled back drastically. They're only doing like 25% of planned procedures compared to previously in order to open up more space for COVID care. And that's why they really only have about 25% of new admits that are not with COVID, that are not admitted because of severe COVID illness. However, if you have 150 people, yesterday was 150, today it's 139, and you take 75% of those, that's still a huge number of really severely ill people. And we do know that with Delta, the relative risk for dying from COVID with unvaccinated people is 53 times that of a vaccinated person. So with Omicron, it's not quite as drastic, but we do know that the people who end up in the ICU on a ventilator for weeks and eventually die are almost exclusively unvaccinated people. And the more the more people catch the infection, and if they're unlucky and are over 50 or 55 and unvaccinated and have a little bit of other risk factor, their risk is really, really tremendously high. And that's why nationally and locally, we still have a huge number of obviously new cases, but also we are reporting huge numbers of daily deaths across the country. And even though it may be less than 1% of the infections that require hospitalization, as opposed to 10% that we talked about previously, just the sheer number of them will add up significantly. So we have way more than in our Delta surge or last other surge. So it's our hospitals are very, very strained, and I hope that this is over sooner than later. So.
Yep. I think we all feel that way, Dr. Ansarg. So, and I guess I have a question of, it's kind of hard to talk about it now, but when it is over, it would be really, I don't think I've ever seen a breakdown of, the people that died. There's this national conversation now going on about, okay, who did die? How many were obese? How many had diabetes? And I know like public health has always had, this healthy eating, active living, change your lifestyle, improve your lifestyle, how that's going to help you live longer. But when we're in the middle of this, we're not really, doesn't seem like we're talking about it that much because we're just trying to get people to stay alive. But that seems to have a huge, the folks that are dying have a disproportionately very high percentage of, obesity and diabetes and other comorbidities that when this is all over, we've got to address again.
Supervisor Williams?
Well, to me, even though the scales are different, it's following the familiar pattern of the last surges, which is, you get high case rates, and then you get higher hospitalizations, and then you get higher ICU, and then you get higher deaths. And as Dr. Ansarg said, there's still 2,000 people dying a day, nationwide. And it's having consequences because you have to adapt to the number of people in the hospital. Have electives been canceled at Cottage, Dr. Reynoso?
Yes, they have. And so at Cottage, they have, and at Marion, they are selectively on a case-by-case basis and more restricted in their electives, and the same for Lompoc Valley Medical Center. So those two hospitals are being selective in procedures, mainly keeping the outpatient electives available and really restricting the inpatient.
And I think that's proof positive that this is negatively impacting the system, because it's not a ideal situation, and I'm sure they, though I support their move, it will have consequences to cancel elective surgeries, which is the possibility of more people having more severe conditions or dying because they couldn't get their elective surgery. It's, we're not out of the woods yet.
Supervisor Hart.
Oh, I'm sorry. One last question, just on the ages, just so that we get a sense of this, the school outbreaks and the numbers that are under 17. Are those mostly teenagers, as we've seen in the past, or is it the younger set that aren't unable to get vaccinated? And if
When
you
we
don't
look-
have those numbers, just what do you see anecdotally through what places are getting outbreaks, elementary or?
we actually have those numbers. So when we look at our pediatric age groups, we are seeing that they follow the uptick in cases in general. At our recent peak, there were 1,546 cases with an episode date on January 10th. So of this, 5% were 0 to 4-year-olds, 24% were 5 to 17-year-olds. I would say that the percentage breakdowns are pretty consistent with what we're seeing.
Thank you. Supervisor Hart.
Looking at the charts that you presented today, it seems to me that the headline is the decrease in cases from the peak. And I just want to make sure I'm reading these charts right. It looks to me like we're down from the peak of 256 cases per 100,000 population to 181. Well, that's a big drop. That's nearly a 30% drop. It's very hard to see the time sequence on the chart. But the other good news is, similar trends at both the national level with the chart that you have on page 14, and then also in California on page 15. Again, the time sequence is really difficult to discern from the scale of these charts, but it looks like, this happened so quickly. The surge came on us, within a month, at the beginning of December, really, I guess about 6 weeks, really. And if the trend line continues, and we don't know, but it looks like it is, we could be on the other side of this in another month or so. And which makes me think that this moment in time right now is particularly important to keep that momentum going, and that our best strategy are masks. If people people clearly have responded to the urgency of the moment and are wearing masks more regularly, being conscious about being in crowds, and we're starting to see the effect of that. And I just want to encourage people to hang in this with not that much longer to get to the other side of that, because we could see as people do this new behavior, the benefits of that accelerate the progress, and we're going to get to a better place quicker. And just want to make sure I'm reading these charts right and understanding that headline correctly.
Supervisor Hart, through the chair, you are reading it correctly. We anticipate, based upon modeling from other countries, other jurisdictions, that we can expect a further decrease in our numbers. But you're also absolutely right that we have to maintain our diligence in wearing our masks, and we have to make sure that our community members are getting vaccinated and are getting boosted. So those are, as Dr. Answerg mentioned, those are very critical strategies as the peak continues to decline. We definitely don't want a movement in the wrong direction.
Thank you, Dr. Dorosa.
And I had a couple of questions. The first is about contact tracing and registering the number of cases now that so many people are doing home tests and they may be positive. So we're not registering those, I take it, or contact tracing. That's mainly in congregate settings. Is that correct?
That is correct.
And the second, could you talk about testing available in the Santa Ynez Valley?
And with the PCR testing at the community site, we continue to look for a site that could host the state coming in and setting up shop. So our team continues to look for that site. And we made sure that in the distribution of the at-home antigen tests, that the various community partners will have access to distribute them in the
Thank
San
you.
Antonio Valley.
Thank you very much for that. And a couple of questions about childcare. If I understand correctly, preschools have been invited to go with aptitude, but much of our childcare in the county is in-home, and I wondered if there's any opportunity to use either the county or Children's Resource and Referral to provide technical assistance to those in-home providers so that they could take advantage of the testing.
Um, Great question, Supervisor Hartman.
It comes from Gina Fisher, of course.
Uh, we were very mindful when we received the cash, the allocation of tests. We set aside a significant amount for unsupported sectors in our community. As you may have heard, what I would say 3 to 4 weeks ago, we had heard that the state was going to allocate to private schools and childcare directly. We now know that the state is having challenges acquiring at-home antigen tests. So it is because your board support our 5 healthcare centers. We have the ability to draw down those test kits from our federal partner, HRSA. So with that allocation, we have set aside a certain amount to provide to our childcare providers. And whether it is partnering with other CBOs in our community to make sure that they know where to access them, we can do some follow-up work on that, but we have set aside allocations for our in-home childcare providers as well as our childcare agencies.
Thank you so much for paying attention to that. And just one other comment before public comment, and that is I really appreciate the discussion on pandemic and endemic. And Dr. Ansar closed, I think it was 5 or 6 ifs, but if these various things happen, but at least it gives us a better framework for understanding how we're going to be making this transition. And that helps to be able to envision what it looks like, that we really can get there. So with that,
Chair Hartman, I just
oh.
have one more question if I can interrupt.
Oh,
for a
yes,
moment.
yes, sorry, I don't see you
No,
always
no,
around
yeah, I
the corner
apologize.
there.
I'd jump in there. Thank you, Chair Hartman. I just had a question about, I know we're really utilizing our community-based organizations to get the antigen tests out there. You know, are we going to go back and kind of monitor those as well? You know, because there's, you know, some of them may have the ability to get them all out quickly. Some of them may not be able to utilize them. Are we kind of checking back in and see if we can't redeploy those? Again, thank you for inviting me to participate with you guys on Saturday. That was a great event. We were able to pass out 6,000 tests in just a few hours.
Wow.
So a huge success. So I mean, I like to see those happen a little bit more often. That's one of the things I got some feedback on social media that people want. You know, now that they knew that worked so well, they like to do that again. So I know the community-based organizations is a strategy, but if some of them can't get them out, I guess I would encourage maybe a alternative strategy to kind of recollect those after a period of time and try to get out through the drive-through approach that we did on Saturday. So just suggestion.
Thank you, Supervisor Nelson, through the chair. Great question. As a matter of fact, we could not give all of our partners all the requested kits that they wanted. So on the first blush, actually, most of our partners, if not all, gave them out within days of receiving them. So now we are on week 2, and we will definitely make sure that those are out the door as soon as our partners receive them. But it is really unlikely that any have any available, since they are very, very vested in pushing them out as soon as they receive them.
And just to follow on, so they report back to public health that they have in fact, used their allocation, distributed?
Yes, we check, and we one of the key guidance from HRSA is that we can't hoard those antigen tests, that we need to push them out to our community members as soon as possible. So it's really guiding and counseling our partners that we will have additional allocations from HRSA. So they really need to push this out ASAP.
Thank you so much. And now, Madam Clerk, to public comment.